Janssens to come up and present the NOMI study, nitric oxide for inhalation to reduce reperfusion injury in acute ST elevation myocardial infarction. Stefan.
Thank you, Mr. Chairman, ladies and gentlemen. If I could have the first slide up. Okay. There we go. It's a privilege for me, on behalf of our co-investigators, to present and discuss with you the results of a novel intervention, an inhalation with nitric oxide, in an effort to reduce reperfusion injury in myocardial infarction patients. As you know, in reperfusion for myocardial infarction, there's a paradoxical damage that increases infarct size and accounts for infarct size due to the reperfusion per se. Now, recent work in animal models, small and large animal models, has shown, as depicted here, that when you inhale nitric oxide, you can target and reduce reperfusion injury by reducing infarct size as a % of the risk area. This is an intriguing observation because the inhalation of NO has been shown quite consistently to reduce the activation of circulating cells and to reduce several activation pathways in the heart that contribute to oxidant and ischemic injury. We tested in NOMI the hypothesis that in patients with STEMI and successful coronary reperfusion, the inhalation of nitric oxide would reduce infarct size and improve thereby functional and structural remodeling of the left ventricle. NOMI was a phase 2 exploratory trial, multicentric, double-blind, and randomized with a control inhalation group that ran in 4 centers, 2 in Belgium, 1 in Krakow at the University of Krakow, and at Semmelweis University in Budapest. We included patients within 2 to 12 hours of their first STEMI and excluded all with prior STEMI, CABG, or PCI. They could not have any evidence of heart failure, needed to have normal oxygen saturation, and signed their informed consent. Importantly, we pre-specified 4 subgroups of conditions that are well known to affect infarct size, as listed here. And importantly, in addition, we defined and pre-specified 2 subgroups of patients that were given either systemic nitroglycerin, a systemic nitric oxide donor, or the use of glycoprotein 2BA3A antagonist. And this is because there was no evidence in preclinical models of the use of these agents, and we wanted to confirm consistency and exclude heterogeneity with the treatment effect in our study. Here's how this study was designed. We randomized 248 patients to receive either 4 hours of inhaled nitric oxide at 80 ppm dose versus 122 control patients that were balanced with nitrogen during that period. Patients were followed during hospital stay for 4 to 7 days and afterwards for 4 months on an outpatient basis. The primary endpoint was measured on the index MRI, which was performed at 48 to 72 hours, and was the infarct size as a % of LV mass. There was several secondary endpoints, which I will tell you relate to LV function and remodeling, and we performed in almost all patients, 99 and 19.8 in the respective groups, a second MRI to evaluate later remodeling indices. We also followed all cardiovascular events across the trial, which was done in 107 patients per treatment arm. Here are the baseline characteristics and the procedural characteristics. It's a common contemporary infarct trial with a well-balanced distribution among risk factors. Patients were admitted within 4 hours or almost 4.5 hours within symptom onset. And here's the distribution of the other confounders that could affect infarct size, well balanced between the groups. I draw your attention particularly to the 45% of patients that were given intra-arterial or intracoronary nitroglycerin, for which the administration was left at the discretion of the investigators in the local sites in the absence of strict guidelines provided for STEMI patients with respect to systemic NO donor therapy. Here's the primary endpoint. In NOMI, we did not detect a significant reduction in infarct size in the overall population. Infarct size was 19.4% in controls and 18% in the treatment arm, which was not significantly different. This was also, there was a consistent effect of the treatment in the subgroups that were affecting infarct size, but importantly, and quite remarkably, when we looked at patients that were randomized and that were not given any nitroglycerin, which was 60% of our population, there was a significant reduction in the primary endpoint. This was not the case in patients that were given systemic nitrovasodilator therapy, which was quite a surprise in that in this latter group there was an increase in infarct size. As for the secondary endpoints listed here, the infarct size, when evaluated against the risk area, as is done in most animal studies, trended in the total population to favor the inhalation of nitric oxide, with a trend towards increased myocardial salvage in those patients in whom we could measure the risk area on the first MRI. Also, when you look at remodeling parameters and global function evaluation by MRI during index hospitalization, there was a trend with a p-value of 0.10 in favor of the inhaled NO group, which remarkably was more accentuated after 4 months, suggesting that there may be over time a greater distinction in terms of functional and maybe structural recovery after myocardial infarction in patients giving inhaled nitric oxide. Now, when plotted, nitric oxide was safe, and when plotted for all cardiovascular events on a Kaplan-Meier, this is what we observed. For the entire study period, there was a lower cardiovascular event rate, and this is for the composite of death of all cause, recurrent ischemia driving revascularization, stroke or rehospitalizations for heart failure in those patients receiving inhaled nitric oxide, which in a small exploratory study as this is quite striking and hypothesis generating. We observed 5 deaths in the NO group over the total length of the trial versus 8 in the control group, which confirmed the reassuring safety profile of this novel intervention. So in summary, we conclude that in timely reperfused ST elevation infarction, the inhalation of nitric oxide on top of standard treatment was safe, but did not receive the infarct size expressed as LV mass in the total population. However, in a pre-specified subgroup analysis, we found a statistically significant heterogeneity of the inhaled NO effect on infarct size in relation to periprocedural nitroglycerin use, for which there are no strict guidelines and hence was left to the discretion of the investigators. Inhaled NO reduced infarct size in nitroglycerin-naive patients. That was a significant observation as a pre-specified subgroup, but it increased the infarct size in those patients that had received nitroglycerin during the procedure. Inhaled NO showed a trend towards greater salvage and enhanced functional recovery, which was more accentuated over time and, of course, needs to be confirmed in subsequent follow-up studies. So we would sum up these data that they suggest that nitric oxide by inhalation might reduce infarct size in those patients that are not given systemic nitrovasodilators. And this pre-specified subgroup finding, together with the robust safety profile and these clinical trends which I showed you, need absolutely independent corroboration in future studies.
Thank you, Dr. Janssens, and we have to really run just now. Are there any key questions? Otherwise, you need to put your questions to Dr. Janssens afterwards. Yes?
How in future studies are you going to tease out whether you should be using nitroglycerine or nitric oxide?
Well, the fact there was 40% of patients that received nitroglycerin, and this was a per protocol administration at one site. So it was not based on the clinical phenotype of the patient, but it was a per protocol infusion that was given at the start of every single patient that was in that site recruited, and which we left to the investigators. So we would pre-specify that there was no use of nitroglycerin NO donors in a future trial.
Okay, then I think, thank you, Dr. Janssens. We have to move on.